cartilage or is extending outside the larynx. Today we have the assistance of CT and MRI, at least.
Okay,
I will say
in
that
the case, if the cartilage is not involved and we have no regional metastasis, how would you treat these cases, Steve?
Yeah, and
also
if there is no
laryngectomy?
invasion of the cartilage, no fixation of the vocal cord, I would say that was already in the 70s in our department and in Sweden, and even when I was over in Toronto, worked with also with the cases from Princess Margaret Hospital, etc., was then primary radiotherapy. At that time came also the preoperative radiotherapy, followed by looking at the effect of the preoperative radiotherapy. If that was well, you continued with the full course of radiotherapy. So most of the cases you are showing here, if they have no cartilage invasion, today will be treated by primary radiotherapy or chemoradiotherapy.
Okay, so that's a clear statement. You, Jan van Morken, what do you do in these cases?
Well, first of all, I have to say that I'm replacing Jean-Louis Lefebvre, so I'm sorry that I missed my French accent. But I think that I just want to support a little bit what Marshall was saying, and that is that the improvement that we have seen in our TAX 323 and 324 trials was mainly an improvement of the local regional effect.
Okay, then would you treat these cases with TPF and radiotherapy? It's a clear statement for the audience. They want to know how we should treat these patients. What would be your...
Well, I just want to make some general statements about how to approach organ preservation, because I think that one of the reasons that Jean-Louis Lefebvre, for instance, is favoring induction chemotherapy is the fact that, what Arlene already mentioned, is that you can at a very early time decide what to do with these patients. So it's a more individualized approach than just saying, I give them one type of treatment and then we will see what happens afterwards.
Okay. Marshall Posner showed in his first study that we have in the phase 2 studies up to 60% complete remission rates with TPF. So,
yes.
60%, you know, in 40% you have no complete remission rate,
yes.
maybe a partial, or
yes.
And then we would decide to wait after induction chemotherapy if he has a complete remission rate, and if he has not, you would not continue the radiotherapy. You would make
in the second trial that was performed by the EORTC, we didn't look only at CR rate, but we look at response rate. So when the patients were responding, they continued with the treatment, with a non-surgical treatment.
Okay.
When they were not responding or stable, then they went for laryngectomy. And I think that that is a very adequate approach because of the fact that we can discuss endlessly about what the cause is of death that is not cancer related, but it is known that when you give chemoradiation and you have to add surgery to it, that it has major implications for toxicity on the long run.
We don't know. But I think what the audience wants to know in these cases, if you make an induction chemotherapy,
yes.
you have a treatment of 9 plus 6 weeks. That means 15 weeks of
yes.
treatment.
Yes.
And what we have to discuss is if this kind of treatment necessary. Maybe TPF has a role in oropharyngeal hypopharyngeal carcinoma. It has a role in these cases. That is a question.
Can we show the cases again? Because today we also have the endoscopic laser surgery treatment. And some people will say that perhaps the one on the left side there with the glottic subglottic extension may also be cured by endoscopic measures today. The one T1, T2 up on the left upper part is a tumor that is extending towards the arytenoid cartilage too. And there is a risk for such a tumor that it extends behind the cartilage or on the lateral side of the cartilage. So it is, even if T1A, for example, now on the membranous part of the vocal cord is treated as well with endoscopic measures as with radiotherapy. This one also extends to the anterior commissure level, and it's a little large to be treated with perhaps endoscopic measures with good functional results as radiotherapy. That is the upper one on the right side may be more suitable perhaps also for endoscopic measures. It seems that it is a more exophytic one, and with the small subglottic extension that could have been treated today, and maybe with endoscopic laser surgery, but not with a total laryngectomy.
Okay, next example. We go to the supraglottic. These cases for the 9111 study, where 60% of the cases have been supraglottic carcinomas. And if you look at the upper right slide, we only view at the upper right slide. The question now to you, how would you treat this case? We begin with Alain first, with the upper right.
So this is a case that we would clearly treat T2, T3. We would clearly treat an N-positive disease. We would treat this patient with, according to the 9-to-111.
Okay.
Yeah.
Jan, what would you say?
We would have an organ preservation approach with induction chemotherapy.
Induction chemotherapy,
yeah.
And if you have remission, you would continue with which
chemoradiation.
Kind of chemoradiation?
Yes.
You?
I would treat similarly. We, in stage 3 and stage 4 supraglottic carcinoma, we would do induction plus chemoradiotherapy unless there was extraordinarily small volume disease or the patient had comorbidities which would force us to do either primary radiation or chemoradiotherapy alone. Ultimately, the survival advantage in these patients is relatively lost with induction because if you do have a failure, or with chemotherapy, because if you do have a failure, you can salvage the patient with a good surgical result. But supraglottic carcinoma is different from true glottic carcinoma.
Yep.
It's more responsive, and I think the responses are actually better maintained. I think when you get true glottic carcinoma, particularly with vocal cord paralysis, the results tend to be quite a bit less positive, both with induction and with chemoradiotherapy in our hands.
Okay, Shadin Shah has a comment. Give him please a microphone.
Thank you. I think it's interesting to note we are into using chemotherapy for nearly 30 years under one or other pretext in head and neck cancer. Intuitively, we have observed that those patients who respond to chemotherapy have inherently better prognosis, regardless of primary site. Whether it's oral cavity, pharynx, larynx, any site. So my question to the whole panel is, by giving induction chemotherapy, are you pre-selecting a biologically favorable group of patients? And the treatment may have no effect. It is the biology of the disease which gives you better organ preservation and better survivorship.
No, I would argue that's not true. And you can take a look at the data that you see in TAX 324 comparing TPF to PF. So what you're seeing is improvement as a result of therapy, not a selection of a better responding group. It's really a circular argument. They do better because they do better. You have to have, if you were to argue that they do better with surgery or with radiation alone, you have to have the comparison to demonstrate it, and I don't think you see that, actually.
But Marshall, if you're going to do that, then you have to include the non-responders into your total organ preservation or organ failure outcomes.
We do. It's not like 9111 where laryngeal preservation is, doesn't include the people that died or have distant mets or have local regional failure in the neck, and then end up with a trach or some other. It's laryngectomy-free survival and overall survival, as well as local regional control. So it does include that. I think there's some data, for example, that shows that we don't do as well, and that generally we're not as effective in the true larynx, T3 true larynxes. There was actually a randomized trial which was aborted in that population looking at induction versus surgery, where the surgery patients actually did quite a bit better. And I think that reflects a biologic difference, perhaps invasion of tissues that are a little more resistant to the therapy. But clearly, there are sites that do better with induction, like supraglottic and base of tongue, where the responses are just enormous and the patients are quite responsive, but the disease is just as aggressive. It's just that they're more responsive.
Okay.
Oh.
Would you answer or would you?
No.
Okay.
I think the great benefit of induction chemotherapy was really to turn the surgical society to see also that it had a benefit to give something else than to perform a total laryngectomy. Yes. Especially in the States, total laryngectomy, a surgical approach to laryngeal cancer, was very, very common. In Scandinavia, in Great Britain, etc., we had a lot of radiotherapy. But you could then select that you saw that there was a chance to preserve the larynx. That was the great benefit of induction chemotherapy. When we are looking at these cases here with the supraglottic cancer, and it's very important, as Yatin Shah said for oropharynx, the glottic cancers are quite different as the supraglottic ones, and the subglottic ones are very few, but they are more aggressive when it comes to lymph node metastasis. Yes. And we can also see that from the epidemiology. In northern part of Europe, for example, in Canada, the States, glottic cancers are much more common. If you are going down to the Mediterranean countries, we find 50% are supraglottic ones, as in South America. Why, we don't know. And they behave differently, and they have good series with for example, surgical primary treatment with external approaches, also for supraglottic cancers in these countries like Spain, Italy, etc., and with very good functional results, but it needs the training. You shouldn't do single cases. And nowadays we have the endoscopic laser surgical approach, very much put forward by Steiner.
And you would treat this case by?
Some of these cases here.
This is the right one on the top.
Plus, could perhaps start with laser surgery, laser resection on the one on the top, to the left.
It's on the right side on the top.
Yeah, it may be also that because that is hanging over the vocal cords, plus then giving postoperative radiotherapy.
Okay, you will perform laser surgery and afterwards postoperative
radiotherapy, including the neck, and also removing the neck if there are positive nodes.
Okay. Fine.
And also the left the one on the left, the lower to the left, but it is depending also on the patient.
Okay. So we go the next example.
Boy, those are tough.
It's a question to you all. It's very aggressive tumors. They are more endophytic on the left side. And what would you do in this case? Alain, what would you make in this case? It's an example for 9111, or would you say laryngectomy? Look at the right case on the top.
Right.
On the right side.
Right. We would use the same approach.
9111?
Yeah.
Yes. Okay. You, Jan?
That is an ulcerative lesion, and probably more invasive than the exophytic ones. I should have. We will give primary radiotherapy and then wait and see.
Primary radiotherapy or radiochemotherapy?
Today, chemoradiotherapy.
Jan?
The same approach that I had in the previous one.
TPF?
Yes.
And then radiochemotherapy?
Yes.
I would do the same, but I want to caution in these patients that it's important that you begin to address speech and swallowing, as Dr. Myers pointed out in the last presentation, that these patients have a high propensity to develop strictures, and if they require tracheostomy before you actually begin therapy, then you're going to run into fairly significant problems along the way. If they're aged, excuse me to my colleagues who are, but if they're fragile, or non-functional, incapable of rehabilitation, they're not going to tolerate a organ preservation approach. So I think it's very important to recognize that we need to address their speech and swallowing at the time we begin therapy. So we would give a patient like this if they were in their mid-50s, 60s, and even up into their 70s, an induction plus chemo-RT approach. We'd have them see the speech and swallowing therapist early. We would really try and emphasize the importance. And if we felt they were not rehabilitatable, that is, they could not participate in their recovery, we would recommend a laryngectomy as therapy for them.
Okay, but interesting is that no one of the discussion